Welcome, everyone, and thank you for joining us for our second monthly seminar series as part of the UABC FAR Implementation Science Hub. We are really fortunate and thankful to have Dr. Allyson Varley, who is a trained health education, health promotion, behavioral scientist with specialty in de-implementation science. Does great work in many arenas, and we feel so fortunate to have her as part of our team here at the UABC FAR Hub. And she's going to give a presentation today on de-implementation science. Welcome, Allyson.
Hi, thank you. So yeah, as Dr. Lanzi said, I am going to talk to you a little bit about de-implementation science today. Before I get started, I just want to disclose that I'm an employee at the Department of Veteran Affairs and also Heart Rhythm Clinical Research Solutions, where I do industry-funded research on atrial fibrillation ablation. However, I've never received any direct funding or payments from any pharmaceutical or device company. My dissertation work, which I cite in the presentation, was funded through a fellowship with the Center for Outcomes and Effectiveness Research and Education at UAB. And then my work on opioid de-implementation has been funded through an internal UAB School of Medicine award that was granted to Dr. Stefan Cortez. And then we've also recently received a notice of funding for a VA IIR to explore suicide following opioid discontinuation. And the views expressed in my presentation are mine alone and don't represent the positions of the United States Department of Veteran Affairs or any other agency. So today I'm going to cover some of the key literature, or what I believe to be some of the key literature on de-implementation science. So when I started my doctoral studies back in 2014 in health behavior, my primary mentor was a de-implementation scholar. And so I was able to get a little bit of training in de-implementation science. However, the majority of my work that I've done to date has been conceptual. And so I hope that if you've done any kind of work in implementation or de-implementation, that you will feel free to jump in and share your experience with us. Additionally, I'll talk about the application of de-implementation science and provide some brief examples from HIV prevention. And then I'll also discuss a paper I wrote with my mentor, Dr. Cortez, related to opioid deprescribing. So to start, the provision of low-value care across healthcare settings is a significant issue today. In 2012, the Institute of Medicine estimated that wasteful spending contributed to 1/3 of healthcare costs in the United States, and over $200 billion of that was attributed to unnecessary care. Over or inappropriate use of healthcare interventions can also lead to patient harms and a slew of adverse events and leading to poor quality. Despite knowing this, we still see overuse of low value and inappropriate care every day. And so strategies are needed to stop or de-implement such practices. And we also need de-implementation science to explore, identify, and test the best practices for de-implementation. And so that's where kind of de-implementation science comes in. And de-implementation refers to reducing or stopping services or practices that are ineffective, unproven, harmful, overused, or inappropriate. And you see a lot of different language in the literature surrounding de-implementation. So I've tried to cover some of the more frequently used definitions. For example, there's a 2019 paper by Prasad that defines the type of practices that may require de-implementation, and those are practices that are contradicted, which means that there's evidence indicated that more recent or higher quality studies suggest that an intervention previously suggested to be beneficial may be in fact ineffective or harmful. So another term is something that's unproven, and that refers to interventions without data, and like the effectiveness of the intervention hasn't been tested. Oh, sorry, yeah, so novel, so I apologize, I got confused there. Anyway, so those are some of the terms that are described in that paper. So then there's also some terminology around the language, the actions that people take when they're de-implementing different practices. And those are reducing the use of a practice, like limiting preoperative testing to patients that meet a certain criteria, replacing a practice with something else, restricting the use of practice within some type of parameter, or removal of a practice altogether without it being replaced, which we often see in deprescribing of medications for like older adults, for example. So a lot of de-implementation scholars believe that de-implementation is distinct from implementation for a number of reasons. You see some theories like operant behavior theory and stuff that try to describe that there's kind of like different cognitive processes that happen when you're going to start something versus when something is being taken away. And then last, I like to point out that like implementation, de-implementation occurs at multiple contextual levels. And, you know, that's something that we kind of discussed last month with Dr. Harold. And he kind of showed us the consolidated framework for implementation research, which represents multiple contextual levels that influence implementation, but in this case, de-implementation. And so for example, de-implementation at the inner setting or organizational level could be, for example, an organization creating a policy to restrict opioid prescriptions post-operatively for certain procedures. And then at another level, like the outer setting, which is like outside of an organization, a federal agency could publish recommendations on a safe dose of a medication, or for example, I'll discuss later, a federal agency could publish a set of practices that they believe to be low value that shouldn't be used anymore. So that is a way that de-implementation could happen at that contextual level. And then thinking about other types of levels, I just like to provide examples where de-implementation could happen. So for example, in the socio-ecological model, at the community level, an example would be like a school system replaces DARE with an evidence-based education program. And then, you know, a lot of de-implementation happens at the individual level. And right here, I've put for an example, when appropriate, an electrophysiologist replaces the use of fluoroscopy with other imaging technology. So I know Dr. Harold discussed like this a lot last month, but and you know, there are hundreds of theories, models, and frameworks that are employed in implementation research. And a lot of those are used in de-implementation studies too, but I think a lot fewer of them have really been applied in de-implementation. And so there was a new paper that came out just a few weeks ago from Callie Wash-Bailey, and it's a review of how de-implementation frameworks have been used. And they found that 27 models and frameworks have been used in de-implementation studies. And as Dr. Harold also discussed, these authors found that published de-implementation studies are using theories, models, and frameworks to assess determinants of de-implementation, de-implementation processes, and evaluating de-implementation interventions. They also found that, you know, for example, like I had just shown, the socio-ecological model is frequently used as a determinant framework in an evaluation framework in de-implementation studies. And then they also found that the most commonly assessed constructs were at the organizational level. And I think we'll kind of see in some of the other stuff that I'll present that oftentimes the implementation is done from an organizational level. You know, despite all of these frameworks being used, a lot of the work in here is still very conceptual, and there's not a lot of empirical evidence on frameworks. So a lot of research is needed, and if anybody, you know, has the opportunity to do it, you should, because there's not a lot of, you know, evidence to back behind what is an appropriate de-implementation theory, model, or framework. So much like theories, models, and frameworks, there's a lot of overlap in strategies that are used in de-implementation work. But again, there's some distinct differences. And there was a really great presentation VA HSRMD did last month by this Dr. Andrea Patey on this paper. And it was really great where they go through all of the different strategies and how they're used in implementation versus de-implementation. But so the paper looks at implementation strategies, which they refer to as behavior change techniques, and compares the use of them in implementation studies versus de-implementation studies. And what they found was there's considerable overlap in the type of strategy or behavior change technique used in implementation science versus de-implementation science. However, they did identify some strategies that were used more frequently in de-implementation. So like behavior substitution, which makes sense because replacing is one of those actions that we frequently see in de-implementation. They also found that monitoring of behavior without feedback is frequently used as a strategy for de-implementation, and also monitoring outcomes without feedback was used frequently, which is, to me, pretty interesting. I'd love to know what y'all's thoughts are on why that might be. But I think I try to discuss that a little bit later too. I don't know how I would feel about not getting feedback on anything if I was being watched. So anytime I try to give any type of overview of implementation research, I always try to cover theories, strategies, and outcomes. So I think it's fair to say that de-implementation outcomes are also fairly similar to implementation outcomes with a few caveats. So just to clarify, when I'm talking about implementation outcomes, I'm talking about like these terms that are listed here. And this is from Enola Proctor's kind of key article on implementation outcomes. But there's a really great conceptual paper on implementation outcomes by Beth Przasik that proposes kind of two important considerations for developing de-implementation outcomes. The first is that when you're studying de-implementation, you want to make sure that you're taking into consideration outcomes related to both the practice, so the removal of the practice, and then the de-implementation process itself. And so that's a place where de-implementation is a little bit different than implementation. So an example that they talk about like in this article is like, for example, if a stakeholder thinks a practice is unacceptable, they may be more likely to de-implement it. However, the de-implementation process itself must also be acceptable. And they give the example that a provider may stop referring patients to a 12-step program if it's deemed unacceptable, but they might not actually do it if they don't have a more acceptable treatment in place like methadone or buprenorphine. So that's a kind of way that you can think about this difference that you need to kind of think about. Is the removal of the practice itself acceptable, and then the method by which the practice is being removed acceptable? And so those are two different ways that you need to look at outcomes when you're studying the implementation. And then the second consideration that this paper notes is that it's important to take into consideration the cultural and historical context of the intervention. And this is particularly important in populations that have historically been stigmatized or have not had adequate access to evidence-based care. Because if you remove if you're removing something when someone's access to care in general is not very good, it could be perceived as like withholding access to care, which could then foster, distrust between the health system, clinicians, and patients. And so you just want to be really careful and make sure that everything is, as we say in everything, very stakeholder driven. So yeah, to ensure that de-implementation is equitable and acceptable, we need to make sure that our outcomes are patient-centered and driven by what's important to them. So implementation outcomes should be measured at multiple levels and include assessments from both clinicians and organizations that are doing the de-implementation and the patients that are also having treatment options or practices taken away from them. And that's another kind of, and I know that, I don't know, and y'all can correct me if I'm wrong, but oftentimes you see in implementation work, unless it's, you know, a hybrid trial where implementation is just kind of a secondary aim, very seldomly you hear about implementation from the patient perspective. And so I think that that's interesting that they kind of stress this, because it's very important, especially when you're taking away treatment options. You're not adding to them. So that's just a snapshot of that paper. If anybody wants to look at that at any greater length, I think it's a really great kind of overview about implementation outcomes. Okay, sorry, I have a cold. I have to take a sip of water. So yeah, now that I've kind of covered some of the background as far as theories and strategies and outcomes for implementation, I was going to kind of go into some examples of how de-implementation science is applied, and then kind of go over a paper where we would propose how we would study de-implementation. So I know originally I said that I was going to discuss the opioid paper, but I also wanted to use this opportunity to kind of look at how de-implementation has been done in HIV prevention and treatment. So I found this paper, and it was interesting in that it presents the results of a national survey of organizations that are providing HIV prevention services in the United States. And so, you know, there's been a huge evolution in evidence in HIV prevention over the past few decades. And so these researchers saw that as a unique opportunity to study how de-implementation of low-value care has occurred in HIV prevention. So they created a survey where they surveyed all these different organizations, exploring the use and de-implementation of 37 interventions that were deemed low value as a part of the CDC's high impact prevention policy. And then the survey also collected information on the organizations and the degree to which the organization had used the low value intervention in the past and whether or not it had been de-implemented. And so they found about half of the time organizations continued low value interventions despite them being endorsed as low value by the CDC. And so this table in this manuscript describes the type of low value interventions that were endorsed by organizations. And so on top of finding that these practices are still being used, they found that only about half of them had been de-implemented. And then they also found that there were very few organizational factors that predicted de-implementation, but they did find that larger organizations were more likely to de-implement low-value care, which to me makes sense given what we know about these broader organizational structures and how they contribute to implementation. But yeah, so I thought that this was a kind of good introduction to my discussion on opioid prescribing, because we see here that specific strategies are likely needed to facilitate de-implementation practice, and that, for example, like publishing a policy and hoping that it's adopted or de-implemented is unlikely sufficient for certain de-implementation efforts. So now I'll discuss some of the work I have been doing in de-implementation of long-term opioids for chronic pain. And so, and just to note that I do this work with my mentor, Dr. Stefan Cortez, who's at the Birmingham VA and also faculty in the Division of Preventive Medicine. And this is, and I'll be talking about the work that we did on his paper. It was published in, I think, JAMA. So opioid use and overdose is a significant public health problem and a priority for like many national initiatives. And in the past decade, we've seen a shift, or as Dr. Cortez has described it, a pendulum swing from under-treating pain to then potentially over-treating pain with opioids. And now we're just kind of trying to correct these two major shifts and find some happy medium. So briefly, in 2016, the CDC published their guidelines for prescribing opioids for chronic pain, which recommends a safe daily dose for people on long-term opioids. And from there, we've seen incredible variability in the way that these guidelines have been disseminated and implemented. And what the opioid de-implementation paper that we wrote focuses on is the process by which people who were prescribing and being prescribed doses that were larger than those recommendations how they've implemented these recommendations and de-implemented opioid prescribing. And so in this little graph that Dr. Cortez often uses, you'll see that we have seen some decrease in opioid prescribing overall. And yeah, so there's been a decrease in opioid prescribing as a result of the kind of movement to decrease opioid prescribing and releasing of those guidelines. So, but unfortunately, the issue that we're trying to prevent, which is overdose and opioid use disorder, has continued to exist and increase despite a reduction in overall opioid prescriptions. And so that's a little bit of a de-implementation conundrum, in my opinion. And on top of that, there have been reports that there are patients being taken off of their medications that they believe that they need, bringing into kind of consideration whether or not de-implementation of opioids is appropriate for everyone. And even worse, there's been some reports of harms related to efforts to de-implement high-dose opioid prescriptions. And so the team that I work on at the VA is very interested in understanding these very complex de-implementation issues. So if overall prescription rates and doses, which was the goal outcome of the guidelines, have decreased, have we successfully de-implemented opioid prescriptions? And I would say no, given the evidence that de-implementation is causing harms in some patients. So before I move on, I just want to note that I'm not trying to say that like all opioid tapering and discontinuation is bad. In fact, a lot of people are doing really well with lower doses of opioids and tapers and discontinuation. But there's a certain population of patients with chronic pain that are experiencing negative outcomes related to the shift in focus on reducing and eliminating them from the treatment of chronic pain. And as we covered earlier, it's critical that de-implementation efforts should be stakeholder-driven and patient-centered. And so that's what the purpose of our paper was. We wanted to highlight that we need better tools to evaluate opioid de-implementation, and the pill count or the dose amount or number of pills that someone is being prescribed is not necessarily a great outcome to measure success in de-implementation. So in the paper, we also propose alternative metrics to evaluate determinants of implementation, and those are guided by the Consolidated Framework for Implementation Research, and I'll try not to go into this too much because I know we just discussed it. So we chose this framework though because it covers multiple levels of contextual factors that influence de-implementation, combining a whole bunch of constructs from a bunch of different implementation theory models and frameworks. And understanding de-implementation context can help us identify mechanisms of action, which can then help us operationalize our de-implementation outcomes. On top of that, there's a lot of resources that are available to use this framework. So they have like a whole beautiful website that has all kinds of stuff, and there are instrument repositories that are linked to it. And I really like that they have linked implementation strategies to the different constructs using ERIC. And then there's the CFR Barrier Buster tool, which then allows you to match strategies to barriers and facilitators within the constructs of the consolidated framework. And so that is why we selected it, so that we could potentially, use the multiple tools available to us. So like I said, the framework consists of 5 domains, and in the paper we propose metrics and questions at each level that we think are important to address when evaluating opioid de-implementation. So the first is characteristics of the individual, and so in opioid deprescribing, there's a lot of individuals that we're talking about. This involves people in the organization that are responsible for de-implementation. And so here we propose some potential evaluation questions that you would want to take into consideration that we consider very important for opioid de-implementation. So based on some of the work that we've done, we know that a lot of people are not comfortable with treating pain within the context of opioid use disorder or inappropriate use. There's also, when a patient disagrees with the course of treatment, there's a lot of shared decision making that has to happen. And I think confidence in your ability to participate in shared decision making is an important thing that we should be measuring before we start, taking people off of their medication. And then again, just clinicians' distrust of patients with pain or opioid receipt. And then there's a lot of distrust that comes from patients with pain. And so here we focus mainly on clinicians because we talk about patients in just a moment. So an example of a measure that would get at some of these constructs is the CAT pod, which is what my dissertation project was. So I used the consolidated framework to create this measure, and it was heavily influenced by clinician interviews. And several of these survey domains cover characteristics of the individual. For example, people's desire to work with this, their ability to use replacement treatments, and whether or not they trust the evidence related to the intervention that they're doing. And then here, just highlighting that beyond clinician self-efficacy and motivation to de-implement, assessing patient access came out as an important domain as well when we were looking to explore people's readiness to treat pain and opioid use disorder. And so again, making sure that patients can access alternative treatments when you're de-implementing something is really important to measure. So another factor we think we need to take into consideration when evaluating opioid de-implementation is characteristics of the intervention. As we mentioned earlier, de-implementation of opioids may be appropriate for some and not for others, and we rarely see that in studies of opioid discontinuation. Because some patients may not need their opioids reduced, it's important to know how flexible the de-implementation intervention or plan is. Again, focusing on that de-implementation process. And then also availability of other options and to what extent are those accessible. So again, like I said, really kind of focusing on not just taking away opioids, but the process by which opioids are taken away. Is that a taper? Is that just taking them away, discontinuation, or are they offered other alternatives? And is that done in a consensual way? So then the next level of the framework where we propose more measures are the implementation processes. And so we, think important questions to ask was there a plan? Was there a protocol? To what extent was the plan executed with fidelity? To what extent does the plan allow for adaptations? To what extent is the implementation process being continuously evaluated? Does the implementation team meet regularly to reflect on the implementation efforts? Are the protocol and implementation processes acceptable? And so then at the inner setting, and I'm sorry, I apologize that I know we just went through all of this, so I tried to keep it down. So at the inner setting and the organizational or the organizational setting, you know, we propose a lot of different questions that we think are important. For example, opioid de-implementation efforts should be reporting on psychological safety, because a lot of times people have reported feeling very out of control and like, you know, they would rather not deal with it just because they don't really have the opportunity to learn when it comes to opioid prescribing. So we also say the degree to which the organizational leadership has committed to supporting de-implementation efforts. We've also learned that messaging, and I haven't really talked about dissemination as far as de-implementation goes, but dissemination of the de-implementation plan or the, you know, evidence behind de-implementation is critical. And the messaging of how that goes out and how, you know, cohesive it is and how much, you know, leadership agrees is very important, because what we've seen is in organizations, especially with opioids, you'll have someone, you know, enforcing a policy one way, but then you have another leadership team enforcing it another way. And so it kind of makes for a very messy de-implementation process. And so again, are there adequate resources to support de-implementation? Do clinicians have appropriate access to knowledge and information to support de-implementation efforts? So for example, we're doing a project at VA right now where we are, and this is not de-implementation, but implementation, but you know, in this example, if you were wanting to take someone off of their opioids, and oftentimes, you know, given the appropriateness of it, some people are prescribed buprenorphine. Well, buprenorphine is relatively new, and we've had a lot of clinicians tell us that they would be willing to prescribe that if they had appropriate access to mentors and people that could support them when they first learn how to do it. And so making sure that if we're going to be assessing implementation or de-implementation of opioid prescribing, we really need to be looking at more than just whether or not pills were lowered or the pill count was lowered or not, the frequency or dose. So here's just some more examples of different validated scales you could potentially use to evaluate de-implementation at the organizational level. This is a scale by Fernandez that assesses culture. So yeah, there's that. And then another example from the same article that is an example of leadership engagement. Like I said, we've seen a lot of mixed messaging and dissemination of opioid prescribing or de-prescribing policies, and that really makes the implementation very confusing. And I think having a clear message about the, you know, benefits and the process is critical in de-implementation efforts. And so that brings me to the last construct that we cover in the paper, and that's the outer setting or factors that influence de-implementation from outside of the organization, which I kind of talked on earlier. But you know, a lot of what we see is how is the policy communicated. So is de-prescribing mandated, and to what extent? So we've seen with opioid prescribing, policies be implemented really variably across the board. So you'll have pharmacies who won't fill opioid prescriptions because they've been told they can't, but however, a physician has prescribed it. We've seen patients, you know, come in with notices from their physician saying that they're not allowed to prescribe opioids over certain doses anymore. And like we said, we have organizations that, I mean, even so the CDC had a certain dose that they said was like a safe maximum, and people have taken that dose and kind of moved it around and stuff too. And so there just hasn't been very clear communication from, you know, policy advisors and then organizational leadership on the best way to implement this in like a clear way. So I always like to discuss the needs of patients outside of the outer setting, because I feel like it's a unique domain to me. But as I've kind of discussed over the past like 20 minutes, I I feel like the needs of the patients being served is often ignored in implementation studies, and definitely in the studies that we've seen as far as the implementation of opioids go. So, we propose a few questions that we think should be asked as far as the implementation goes to patients. And so, how satisfied are the patients with their care now that they've had this treatment option removed? And we like to say pain should be an outcome that is studied in these assessments of opioid de-implementation. If people are if doses of pain medication are coming down, is their pain improving overall? Do patients have access to alternative treatments? If so, do they have all of them, some of them? How can we make that equitable? Is it equitable? Are those alternative treatments acceptable to patients? Is the de-implementation or taper plan acceptable? Is it consensual? Do the patients feel like they have autonomy over their treatment? And then also, how does this change in medication affect their quality of life? And so Beth Darnall at Stanford has a large PCORI-funded project where she's testing a patient-centered opioid tapering program. And these are some of the examples of the patient-level measures that they are assessing as a part of the project. And as far as, and these are, people that are being consensually tapered, they're choosing to be tapered off of their medication. And so she has a few really great patient-centered measures related to that. So to kind of sum up the purpose of the paper, there's been a lot of focus on using dose or number of prescriptions as the outcome that defines success in opioid de-implementation. But as we call it, the pill count fails to assess a lot of really important implementation outcomes across all of the contextual levels we know are important when considering, when trying to understand implementation and de-implementation. And because of our interest in this phenomena, Dr. Cortez was just recently awarded a VA grant to conduct a case series of social or psychological autopsies on individuals that have died by suicide following a decrease in opioid pain medication. We've assembled a very large team of stakeholders from different departments of VA, patients, and then nationally recognized scholars in pain, addiction, and suicide to conduct this work, which we consider to be a needs assessment for the long-term goal, which will be developing and testing strategies to improve opioid de-implementation and make it more patient-centered. So, in conclusion, de-implementation involves reducing, restricting, replacing, or removing practices that are overused, low value, inappropriate, or untested. While there's a lot of overlap in theories, strategies, and outcomes with implementation, de-implementation processes are pretty distinct from those in implementation. De-implementation is very nuanced. And so it's critical to measure de-implementation at the patient level to avoid harms and exacerbation of any existing disparities. And we must measure what matters to stakeholders when assessing success in de-implementation efforts. So that is it. I did want to say that I'm always happy to discuss any of these topics or how to apply these in your work within our discussions here with the ISTE, but also at our Dissemination, Implementation, and Improvement Science Core Happy Hour that's held monthly. And that's it. Thank you. I'd love to hear questions, or if you have any experience with opioid, or not opioid, but with just de-implementation and your experience of that.
Thank you, Allyson. I just want to tell you congratulations on a wonderful presentation, and thank you so much for sharing such great expertise and hope that you can see all the claps that you're getting across the screen. So yes, let's open it up. Questions or comments?
Has anyone done any de-implementation work? Like I said, I mean, I know a lot of what I read is very conceptual, and a lot of my experience is conceptual. So I would love to hear about anybody else's experience, whether it be with research or practice, as far as the implementation goes.
Well, I guess I could chime in on one thing. Susan and I have been furiously texting each other during this presentation because of the McKay article you shared around the deprioritization of a lot of the social behavioral interventions that CDC used to support. And we had been a CDC funded capacity building assistance provider for more than 10 years. And it's just interesting I was sort of browsing through that paper that you shared. And it's interesting that, you know, when the determination of what's low value, I think changes over time based on funding agencies' priorities. And, you know, I can certainly see why CDC makes a case that they want to be the most efficient as possible with their national plans. But if an organization's mission is to serve, you know, homeless and runaway youth with services, and there's a project like Street Smart that serves homeless and runaway youth, and it's an evidence-based intervention that's shown to be effective, and, you know, the vast majority of their participants are young MSM who are at the highest risk of acquiring HIV infection, you can certainly see why an organization might not think that it's a low value intervention, even though CDC is no longer funding it. So it's kind of that low value term, I think, needs some qualifications with it, because it may be low value. I mean, I guess it's hard because I wouldn't think that some of those, or, you know, a lot of the organizations that were serving Black women in the US when CDC defunded SISTA because they realized it was too expensive to bring to scale and, you know, really make a dent in the, you know, to really reduce enough number of HIV infections. That's one thing, but if an organization's mission is to serve Black women with HIV prevention services, and there's an evidence-based intervention to do that, calling the intervention low value, I think, does a disservice to the organizations and to the intervention and to all the effort that goes into it.
Yeah, and I mean, I think that kind of just goes back to the implementation is very complicated because it's not just introducing another option, it's taking something away. And like, what is low value seems to be very, you know, everyone can interpret that differently. And again, I think it's very important to understand, like you're saying, what the population or the patients need, because when it, you know, comes down to that, that should be very important when you're kind of planning these de-implementation projects. And also, I guess when you're considering what's low value, because, you know, I don't know very much about HIV prevention or the history of these programs. And so I just like kind of read that paper, but it's very, you know, to me, what you've said makes sense. And I'm like, oh, well, then I wouldn't consider that like a low value practice either. So I
your
think
point of view.
Really, yeah. So I think it's, you know, interesting and complicated.
Yeah.
Yeah. And that was true of a number of the interventions that we saw listed, is that they'd gone through, they were funded by NIH to begin with, they were shown to be efficacious, and they moved into practice. And then the CDC, which really favors medical interventions over behavioral or social interventions, decided to defund them. And their process of deciding isn't externally known. They don't explain why they decide some things. They just say general things like epi, which sounds great, but you don't really know. And epi is very different in different parts of the US about the epidemic. So looking at that, you know, and thinking about organizations and their commitment to whatever they've spent a lot of time learning how to implement, and then suddenly being told, oh no, that doesn't count anymore. And yet they have the patients, the people right there in their community who need services. So it is kind of tough thinking about, and I'm sure that's the case with a lot of programs, is that they've moved into practice and then someone else says they're low value. And that's not the experience of the agency necessarily. So I can see why they hang on.
Yes, so and that's another thing that, and I was kind of mentioning the like dissemination plan behind these policy level de-implementation initiatives. I think based on my experience, I mean, on what you've just told me about this, and then also with my interest in opioid prescribing, is that oftentimes just a paper that recommends something is not enough. And, Bertha does a wonderful job of disseminating really complicated science to everyone. And so I just think that if you're going to come out with recommendations that are really complicated like that, when you know that a significant number of people are using this, there needs to be some due diligence as far as making sure that the evidence for that is communicated correctly. And then also kind of, which I've described, this very heavy kind of understanding of determinants of implementation to understand whether or not de-implementation is appropriate or not.
Yeah, yeah.
And now it makes sense why about only half of those practices were de-implemented.
Right, because they weren't replaced with anything else. You're an agency in the South. You see tons of Black women who are vulnerable to HIV, and then the CDC says that's no longer a priority intervention because we don't think that the population's much at risk, but they're still seeing it. And anyway, it's why it's the Centers for Disease Control and Prevention.
Really great points. Thank you. Any other comments or reflections?
I guess we did other implementation research earlier than, and we worked with organizations all across the US that were implementing the intervention we developed. And I always thought of it as you're trying to get the train to slow down. The train is on a track and it's going somewhere, and you're trying to get a new intervention implemented, but you need to slow down that train from what they're doing already. And that's very difficult because organizations can be very, very attached to what they're doing. It's just not, it's a really hard thing to switch over to something new.
Yeah, and that really adds to this idea that we use and I felt like there's so much overlap in that we use the same theories, we use a lot of the same outcomes, we use a lot of the same strategies, we would use a lot of the same study designs when studying the implementation, but it's very different to offer something new versus taking something away. Mm-hmm. There's a lot of different processes that are different there that have to be considered.
Yeah.
And like you said, is there anything else is sometimes important when that was the only thing there that offered any support for whatever the issue was.
Right. Right.
So thank you for that. I've started thinking deeply about de-implementation as you were speaking, because that's certainly a valid perspective, because there's a lot out there that's not necessary to be. But one interesting aspect of your presentation was the idea of replacement that everybody has been talking about. And I'm thinking you might have to have two plans ongoing at the same time, an implementation plan as well as a de-implementation plan. And sometimes
Definitely.
sometimes they might be contradictory, because you have so much consideration for what you're trying to de-implement. And at the same time, there needs to be a buy-in to what you need to implement. I don't know what the group's thought is about that.
One of the things that makes me think about is clarity from the beginning about the end game. So in the beginning, is it that the patient, let's talk about opioid use, that the patient has an understanding that after 3 months, this is what's going to happen, as opposed to here, use your prescription, you get your relief, and you continue to feel the relief or the need to have more to continue to have the relief, but not knowing what that you're going to not continue to have it. So I think some of it is clarity from the beginning. This is going to be the de-implementation. And while we're implementing, here are the tools that we're going to also provide or share with you so that you can use after, say it's the opioid use is no longer. So the variety of things that Allyson shared that could be potentially helpful for pain relief. And of course, the issue of equity throughout. And so I think those are, one, the clarity, and then planning for the de-implementation from the beginning so that the patient or the person has that mindset and goal to know how to plan for it and think about it. Also, before that, having the opportunity to discuss with them before they're even starting it, like what would be good? How can we work together? What are my resources in the community? What are the resources we need before we start this process so that we can start it knowing together, collectively, collaboratively, that we plan for it. Because that part, I think, before you start even talking about, okay, let's have clarity on what's going to happen once we start and implement and then de-implement during that pre-implementation stage to have the community with, discussing, okay, this is what's available, this is what I need, this is, how it's going to work for me, this is what the home life looks like in our community. And so I think that's sometimes one of the missing pieces as well.
Yeah, I'm thinking from the perspective of, context, whether as you're considering the models, theories, and frameworks that inform the plan, that some there, some could be, there could be opposing ideas about how to actually get to that implementation stage, right? Like the determinants, you have to consider two sets. It's almost like doing two sets of experiments where you're considering different determinants for implementation and de-implementation. And maybe that doesn't matter, but I think it does, because you're almost at a place where that those disparities that you mentioned are really real for me, and for a lot of places that are under-resourced. And in DC, we certainly have a lot of that. There are practices that really could change. But putting something in place, and while you're studying, or how to remove something else, it seems difficult and complicated, and maybe I'm making it more complicated than it needs to be. But it's just food for thought, I guess.
No, I certainly think that that's important. And like, that was kind of the message I was trying to get through, is that it is complicated. And so understand, when you're thinking about your outcomes and how you define success and the implementation, there's a lot of different contextual factors that you need to take into account.
Well, thank you all so much. Allyson, what a great presentation, and just really bringing together a lot of things to think about and plan for, as many of the projects actually are not launching new. We're thankful to have also a project here who's in their second year. So thank you for all of you for joining, and our research team here at UAB for joining and supporting. So look forward to seeing you all at our next monthly seminar in January. Have a wonderful holiday.
Thank you very much.
Thank you. Bye-bye.
Hi, everybody.
Bye, thank you.
Thanks.